Hi, today we're going to talk about something I think it affects 89.9% of the population of the United States. So that's pretty much everybody, right? Your brain is shrinking whether you realize it or not, and it's shrinking probably faster than any other former generation that has lived in the United States, and even back to Aboriginal. So I think there's something we need to look at, the why, and then we need to look at how we can change that. It's going to be pretty interesting. Why your brain is shrinking and how you can change that. So here's the healthy brain, of course, and you've probably seen various pictures of this, and you'll see some more today on this particular presentation. It's like, why does your brain atrophy? Why does it shrink? And it actually does shrink, and we'll show you some actual pictures of how this happens. Widening of the middle part, what they call the cortical sulci, enlargement of the ventricles, thinning of the cortex, the outside, and here's the part that you see in others. Here's the part you see in your great-grandparents or your grandparents or your parents or your partner. Why are they not remembering? Why is learning more difficult for them? Why? It's the hippocampus right here. This is the area that is most vulnerable to how they can communicate with you and understand the world around them. Okay, to be clear, we're going to be talking about cognitive impairment, from mild, MCI, mild cognitive impairment, to severe. We are talking about brain fog and various conditions that relate to that level of just not feeling you're very clear, to very organic and well-documented brain shrinkage, cerebral decline, dementia, normal, mild cognitive impairment, and Alzheimer's disease. And this is a PET scan, so this is a measurement of your uptake of glucose. So the activation of what part of your brain is active. You can see it's getting less and less and less, but you also can see the cavity within the brain that's appearing. And choline. Choline is going to be the hero in this particular story. All right, so 5 groups of people should be paying attention to this information. Pregnant and lactating women, vegetarians and vegans, postmenopausal women, the forgotten men, we'll just say men, but I say forgotten men because they're never really talked about relative to choline. Anyone seeking support for cognitive health, liver function, and brain shrinkage. So brain volume does decrease with dementia. It's pretty well documented, and I put it down here, basically saying, here we have all-cause dementia. That is, why are people not responding? Why? So dementia is basically a cerebral diagnosis. It's not looking at the brain. It's sort of saying, they're not with it. They're missing things. Don't know who they're talking to or about, and don't understand where they are or what the time is. And there's ways to evaluate that. However, when you look at the actual brain, you find that sure enough, with time, this goes a number of regions of gray matter, you have white and gray matter, atrophy. It gets bigger and bigger and bigger, and these are basically the quartiles, right? But it shows that Alzheimer's is pretty much the same thing right out of the gate, except that Alzheimer's gets even worse. But there's another part called vascular dementia that has nothing to do with brain atrophy, brain shrinkage. That's about not getting the oxygen to the brain because you have a cerebral vascular, and more than likely you have a cardiovascular situation. So it's about blood flow in that situation. Here it's about you don't have the machinery is disappearing on you. Okay, so what it looks like. Normal brain versus advanced Alzheimer's. It's not just Alzheimer's we're talking about, and there's many ways. If you were to look back, this is imaginary, if you were to look back through the life tube of all the people who were diagnosed upon autopsy with brain shrinkage, Alzheimer's, you would say, well, how did they come to Alzheimer's? There is many different ways to get to Alzheimer's, but brain shrinkage and that sort of clearly autopsy, diagnosis, and documentation is what we're looking at here. Your brain doesn't have to shrink. Your brain doesn't have to shrink. So I'm assuming it is shrinking. That's my assumption, but it doesn't have to shrink. So this reflects not only the brain of elderly people, there you go, so it doesn't have to shrink. The brain of persons with Alzheimer's, and that was, I'm sure there's a big scale of that on Alzheimer's, from really terrible to not as bad, but also a person with alcoholism. Alcoholism, we're not just saying drinking alcohol, we're saying alcoholism. They drink a lot of alcohol and it has caused liver repair, and that consequently has caused brain repair. This comes from a study called ViaCog, Vitamins and Cognition Studies. It came out of really a 10-year period in the UK, Cambridge University, And this is normal brain versus Alzheimer's brain. Again, a PET scan showing there's a big difference here. But it's also showing that they looked into vitamins and other labs and saying, hey, can we get other parameters here about dementia and Alzheimer's? Maybe there's something here we can treat. And sure enough, there was a lot there you could treat. Okay, so mild cognitive impairment, MCI, confronts 5 to 20% of Americans over age 65. I'm sure it's a lot higher than that, actually. The risk of higher is among people who have a high blood level of homocysteine. And that's what this says. High homocysteine and mild cognitive impairment both predicts a higher risk for developing full-fledged Alzheimer's disease. I'm not going into blood work on this particular presentation. It's long enough and you'll curse me for it at the end. But homocysteine is a big deal. We've broken it down relative to insulin resistance and relative to other conditions and along with other labs. But homocysteine is not an esoteric lab. It's one that you should be getting done. And should you want to get it done, there's a link to where you can order this for yourself on the description. We get nothing out of it. I suggest that you do exactly that. How did this happen? And is this happening to you now? I'll show you how it did happen. And it is happening to you now. There's a healthy brain, severe Alzheimer's brain. Again, healthy versus unhealthy. It is happening, and it does happen to a lot of people. So there was a study that I went over before that I'm going to reach back and use this as sort of setting the stage of what we're going to talk about. So this was a study of roughly 60 people, 57 to be exact, of premenopausal, postmenopausal women and men. And men made up between a third and a half. And so what they did, they took everybody into a diet that they could measure everything. And they all had, this is on choline now, they all had 550 milligrams, the highest recommended level for what they call AI, adequate intake. So 550 milligrams of choline per their body weight, and that's how they put that unit in there. So everybody got up that level, and then they dropped them down for a period of a month and a half to be depleted, right? To be deficient. They were inducing choline deficiency. And they were measuring liver enzymes, they were measuring kidney enzymes. They were also doing an MRI of the liver. They didn't do anything cerebral, nothing of the brain. That would have been probably too expensive. And then they repleted them gradually, up a little bit, up a little more, up a little more, and then 100% back to the 550, right? So they didn't go beyond 550, except for a few people. All right, that's the study on that where you can go. We've talked about it at length about that. So here's some of the breakdown I wanted to point out to you. So pre- and postmenopausal women and men. So these are the three categories, and here's how you read it. These are the number of people across the bottom in each category who had a certain response. And this is postmenopausal women. This means they did become depleted, which means they could find in women, primarily it was about liver damage. So they found liver enzymes went up 5-fold from their baseline. So what we had at the 550 level, there were still women, so that is about 4 women out of the total of about 30 or so, that did still have liver problems. In other words, that amount of choline was not high enough for them to have a normal liver baseline. Okay, and then you go down, as you start dropping the amount down, you see other additional women would then get into having liver function. And none of them had muscle function, oddly. And so when you finally got down to the 50, that they did that for a month and a half, some postmenopausal women did not have any problem. So now we go to premenopausal women, and they can make their most, a non-SNP problematic, mutation problematic person, a woman, would not have a problem. So most women, premenopausal, can make their own choline, so they shouldn't have any problem. And that's really how it worked out. And then it showed that below the 50, most of them did not have any depletion. So they were all set. They're a little package, they can make their own, but there was a few exceptions. And then with men who have the highest required amount for life, from late adolescence through all of their whole life, they have the highest amount. And at each level, there were some at that high level, the recommended level, weren't getting enough. They were still having, for them, it was mostly muscle problems. As they dropped the amount down, there was obviously additional men that were having more and more problems. But there were a few men, a total of 6 men, even at the lowest level, didn't have a problem. So it goes on both sides. So what I'm trying to show you here is, their adequate intake was 550 for postmenopausal women. It's the same as men, right? Men is 550 for their whole life. but for premenopausal women, it's less, with the assumption being that they're healthy and don't have these SNPs, and therefore can make as much choline as they need. So for men, what I wanted to point out, I see men as actually the most vulnerable group of everyone relative to choline deficiency, because they have this high level. After adolescence, they have 550 milligrams per day per 70 kilo body weight, but the highest amount for men, and I'm going to show you, they don't get there. And so what does chronic deficiency look like? So what I went through, and I said, all right, in the men, of the 26 men, some had muscle dysfunction alone, one had liver dysfunction alone. This is at the recommended level. They were the non-depleted level. And then they had, and 4 had both liver and muscle. So then when on the depleted level, of course, the numbers are going to go up. Muscle, liver dysfunction was high, liver and muscle was much higher, but 6, as I pointed out, did not have a problem. And then you go with postmenopausal women, are interesting in the sense of no problem until they were depleted and they had a lot of problems. Premenopausal women basically had no problems throughout. There were 9 that had a problem when they dropped it down, but for the most part they were free. But here's the big surprise, that I didn't bring this up before. It's just fun to read studies because you get a lot in this study that's not part of the data. 100% of everybody who was in this study, all 57 people, men, women, premenopausal, postmenopausal, all had an elevation in the uric acid. They had an elevation in uric acid from baseline, from where they started, that did not come back to normal after they were repleted. So serum uric acid concentrations, a measure of cell death, increased in all subjects fed the low choline diet, right, for that month and a half, and remained significantly elevated at the end of the choline repletion diet. So why did this happen? What happens with choline depletion is, as you can guess, your immune system starts to fall apart. The first part that is noticeable is your lymphocytes, which is part of your white blood cells, start to fall, they die, apoptosis. And so as the cell dies, that's what you're seeing, is the uric acid goes up with cell death. Okay, again, premenopausal women, postmenopausal women. So the conclusion of all that is this: we really don't know how much is really required even today. Today being 2022, and that was done in 2007. So the adequate intakes, AI, what does this mean? The definition of AI is that this is the amount that's assumed. If everybody had this, nobody would be deficient. So that's the definition. But we just showed you at least a third were deficient. So there's the amounts. The men should have 550, women 425 if they're premenopausal. Pregnancy a little more, and lactation is 550, is equal to men. It is the amount that's believed that at which most people won't be deficient. It's not what is required, and it's not what is absolutely necessary nor optimum. It's to avoid depletion, to avoid deficiency. And that number's off, but it hasn't changed in 20 years. So here's another way of looking at it. Actual choline intake versus requirements. So pretty much the data that I've given you is upfront, and these are the amounts. So you can see the difference. The only ones that are even coming close are kids. Men, big difference, for their whole life. So times that 60, 70, 80 years, do you think there'd be a problem? Times that 5 years, 2 years. Here's women. 260 to 425. There's pregnant women, still not getting enough. There's lactating women, certainly not getting enough. Think of their children. And there's men, again, over the age of 70. The amount hasn't changed, so it's men and men. And that came from Institute of Medicine, which is the institute that's responsible for establishing these particular standards. Okay, so only 10.8, we'll call that 11, right? So 89.2% of Americans are not, over the age of 2, are not having enough choline. So they are choline deficient. Most of us are choline deficient. Men were 402, but their AI, and we already said a third of that experiment, we were not even getting it. So according to the AI, they're 100 and call it 150 below times 10, 20, 30, 40, 50, 60, 70 years. Do you think there'd be a problem? And women likewise, round that up to 300 for easy math. There should be 425. So they're at least 125 deficient for a lifetime, and so on. So this really begs the question, what would result from chronic choline deficiency that lasts 10 to 80 years? Well, I'm going to show you that. Choline requirements by age. Again, I've listed it this way, and notice the difference between men and women. Men and women. What is the difference between men and women? Talked about that a couple videos ago, and that's about their SNPs. while in their fertile years, their premenopausal years, they have the ability to make their own choline. So not much of a problem. Postmenopausal, their requirement needs to go up to the level of men. So the conclusion is a daily intake of the current AI was not sufficient to prevent organ dysfunction in 19 of the subjects. That's 19 out of 57. That's 33%. Seriously amazing at any standard. You should be interested in choline, that it's not just another nutrient. It's for pregnancy outcomes, it's for cognitive function, it's for liver function, it's for muscle function, sarcopenia. 4 functions of choline. Nearly 100% of dietary source of choline is phosphatidylcholine, otherwise known as lecithin. And you get that primarily through animal protein. So anything you eat, I call it the cell wrapping. It's the fat that goes around every cell. Yes, you can get some of it through vegetable sources, far, far, far more difficult. And I've listed all the sources before. Not going to go there today. Methylation, so the functions are methylation as a methyl donor, membrane function, every cell, so it makes phosphatidylcholine, the cellular wrapping, neurotransmission, it's the source of acetylcholine for brain and function, for brain and muscle. It's the #1 neurotransmitter in the brain, and it is responsible for muscle contraction. It transports DHA. DHA is one of the fish oils, EPA, DHA. It transports DHA, the dominant fat in the brain. More on that coming up. So muscle mass decreases with age. Is this a result of acetylcholine decline? It's not just they're sitting around and less active. That's part of it, clearly. But there's more to it than that. Okay, methylation is a methyl donor. Get a little technical here. What the heck is that? Keep on bringing this up and I'll try to take another swap at it. Methylation is a reaction in which a methyl group is attached to a molecule. So think of it as a pin going into a pin cushion. When it gets pinned with methylation, it turns that gene off. And there's reasons we want genes to turn off. We grow, we have a lot of genes that are on, but once we stop growing, we want maintenance. Certain genes that are on that we need to replace, and others don't need to be on all the time. So it's the ability to keep the appropriate amount of genes and specific genes off and the specific genes on. That's your methylation pattern. And you want to have a healthy methylation pattern, and that's actually what they base your aging on, is how unhealthy is your methylation pattern as you get older. So you heard about those methylation clocks. Okay, so here's choline. So I want you to see choline, which is primarily egg yolks and liver, the best sources. See it as that pincushion of 3 methyl groups. So our methyl group is basically this. If you have to visualize it, 1 carbon, 3 oxygen. We're really not going to get into molecular chemistry here, but I think you need to know this because we're going to keep on talking about methyl groups and what it does in methylation. So methyl groups is CH3, or visually represented this way. Okay, so it's sticking it on and then taking it off. Methylating is sticking it on. So choline has 3 methyl groups. So it's like a little package. It's like if you think of bullets, they're like bullets for your gun or staples for your stapler. Okay, so there you go. Notice the similarities, but choline and betaine. So choline makes betaine. Once it's eaten, part of the 2 routes that choline goes down to is immediately go into betaine, and that's about the methyl group, and then it goes over to be made into phosphatidylcholine for that cellular wrapping. So notice 3 and 3, they are chock full of methyl groups, and methyl groups, like ping pong balls, are stuck on when it's needed to. They need to have that. You need to be methyl groups rich, right? Otherwise known as trimethylglycine. I showed what glycine is over here. I wanted to take a little description on what glycine, they find it in comets. It's a neurotransmitter in all living animals, by the way. It's a fascinating story behind glycine, but we're not going to go there today. Okay, so the big picture of methylation, and this comes from Strategy. It's a company we use to give reports, but there's other good companies out there too. But this is trying to give a big picture. Here's your methionine cycle, otherwise some people call this the methylation cycle. Here's your folate acid cycle. So you have folate, B12, homocysteine, that's a lab we've told you about. Too much homocysteine is toxic. It's been associated with high risk of Alzheimer's and dementia. Okay, and choline has a lot to do with that. So just notice this big picture, a couple rings. There's choline comes in here with PEMT. We've talked a lot about that before. Homocysteine, glutathione, folate. So in one way, I used to call this, and it's a fine name, to call it as a glutathione factory. All these things come together, and these are various enzymes we're going to look at that people have SNPs for. The purple means it's very slow. This happens to be my report, so they're saying I'm very slow. I knew that. They didn't have to tell me. But this is basically giving you the bigger picture. All right, so problematic SNPs for choline synthesis. And I just wanted to show this a slightly different way. There's homocysteine, there's methionine, and so now it says, wait a minute, there's all these other things that feed into MTHFR. Remember that? MTHFR? Right over there, MTHFR. So this sort of elaborates it. It gives a little more detail, and you can get lost in all the detail. Believe me, you can. But they're saying this is well known, well documented. I'm giving you the obvious ones that people will look for problems. Here's choline coming into the body. You just had it. And you take it as phosphatidylcholine, it breaks it down. It breaks it down into choline and then actually builds it back up into phosphatidylcholine and other phospholipids like phosphatidylserine and so on. But I wanted you to know homocysteine, methionine, and the problematic SNPs that people have. It's interesting that back in the 90s and early 2000s, before all of this was sort of conversational at a medical practice, is that for some people, this is just a supplement, SAMe, S-adenylmethionine. They would take SAMe, and some people would have an amazingly positive reaction. It was mostly used for depression and borderline kind of schizophrenia, bipolar, but that was a bit on the higher risk side of thing, but mostly for depression. Some people are like, wow, I've had like a cloud lifted from me, they would say. Others, not so much. We didn't know all the details of this situation. But what they were doing is they were giving SAMe, which is derived from choline, to a person that was choline deficient. So of course it would benefit nearly everybody, but it would certainly benefit those who had the SNP problems. So this is phosphatidylcholine. This is the cellular wrapping. People tend to think of, oh, I heard about this in high school. Yeah, well, maybe. I hope you heard about it in high school. But it is hugely important, and especially when we become deficient. So phosphatidylcholine by itself, the membrane function, the wrapping of every cell, reduces fat accumulation in the liver, reduces reactive oxygenated species, improves Hep B and Hep C. This is just phosphatidylcholine. Lowers liver inflammation, lowers liver enzymes due to liver damage, protects against chemical toxins and medications. So remember, the 89.2% of the population is choline deficient, which means that giving phosphatidylcholine, which is something we should all be having enough of, but we don't, giving it to them is like, look at all these things have changed. So these problems are problems due to choline deficiency. But the most important, in my view, is transporting the DHA, right, one of the essential amino acids, into the brain, because DHA makes up 90% of all essential fatty acids in the brain, and it makes up 35 to 40% of the fat in the brain. So it's a big deal. So what I'm saying is that you don't get this. The empty parts of the brains that we just saw at the beginning of this, those are DHA, it's phosphatidylcholine. And if you think of phosphatidylcholine at the bus, and DHA is the pickup, taking the little kid to his first grade class or whatever, is that the bus stops showing up. So it really doesn't matter. Taking DHA and fish oils clearly would help, but phosphatidylcholine is the transporter. Come on in, come on in. And that's why it's co-equal, if not more important, than DHA. So here's yet another mutation that I have found involved with choline to acetylcholine production. And this is taken from me because I can be a little more candid about showing it. I have to worry about who I'm talking about. So I've covered MTHFR before. This obviously impedes the ability of folate for me to methylate my B12 to become methylcobalamin and to methylate my folate as well. And so that's a big deal. And I have the worst of the worst genes there. But this others, again, I'm taking it from Stratagene, is that I'm heterozygous for that. So it's another impairment on the folate side of things. Heterozygous for these two mutations, homozygous for the MTHFR. Okay, so this is more from that report. I just want to sort of, this is somebody else I just pulled in. So of all the reports I get, I decided to pull one in, and obviously it's anonymous. And this person has homozygous for that PEMT. I'm homozygous for the PEMT. And I just showed you, no I didn't. And these are more problems that I have that I'm heterozygous for that have to do with methylating folate and B12, so additional levels. But the PEMT has to do with choline specifically. So again, the 5 groups of people should be paying attention to this: pregnant lactating women, vegetarians, postmenopausal women, forgotten men, and anyone seeking cognitive liver health. Pregnant and lactating women increase choline demand because they're growing a fetus. 90 to 95% don't get enough. Prenatal vitamins don't fill the gap. And here's another study. It says maternal choline supplementation during the 3rd trimester improves information processing speed of infants. So I don't know if you remember this or not, but in a woman's pregnancy, the last part of her pregnancy is when her estrogen is the highest. And so that's where the choline need is the greatest. And so what we're seeing here is that those who increased, pretty straightforward, information processing speed, they measure it slightly differently, and they basically said the higher amount that showed faster ability to cerebrally react to that. Pretty interesting. And there's become a number of studies. This has become a whole field by itself. So choline is critical to embryonic development, supports neural tube development. That's an understatement. You've heard about neural tube defects, you've heard of spina bifida, cleft lip. A lot of these things have to do with choline deficiency. So it modifies epigenome, which is what we're talking about. Epigenetics is what we're talking about. Okay, so much more to present on this specific topic coming later. All right, so vegetarian and vegans, I didn't really give a lot of detail here because I've covered all the best sources. But what I can say to support vegetarians and vegans here is that choline is really difficult to get through vegetable sources. You can get beta-ine, which is the next product down that I showed you, right? And that is helpful. That is also a methylator. And you get that through actually wheat germ, and a number of other things, soy and so on and so forth. But all in all, choline is very deficient in terms of vegetable sources. So postmenopausal women, lower estrogen, right? We know that. We've talked about that before. Okay, so one of the problems, and I did this in another video about weight gain for postmenopausal women and why that is and how to change that, but specifically what happens is obviously their estrogen has fallen, and so consequently, because estrogen promotes endogenous choline production, that they are good, but when their estrogen drops, they have no way to create choline, and if they were never having a very much choline in their diet, if they were already deficient, but they made it up because they could make it up, then suddenly they're going to be into choline deficiency, and part of choline deficiency is fatty liver, part of fatty liver is belly fat, is weight gain, part of weight gain is obesity, and then you can even roll it right into diabetes. So here's premenopausal women, their brain, right, looks pretty full and active. Postmenopausal women, you can start to see the activity has dropped considerably. And women have twice the rate of dementia than men. Okay, in part it's because they've had this free ride, if you will. They could make their own choline. Men had to sort of figure it out for themselves, if they did figure it out. And once that gravy train stopped and nobody told them that you needed to up your choline, that's what's going on here, they're going to really be affected badly. So dementia is the biggest killer of women in the UK. And you got to wonder why women are different than men in this regard. Okay, menopause triggers changes in the brain that may promote Alzheimer's. This is Cornell, 5 years ago, saying this. Okay, estrogen, part of the story. There's estrogen. The other thing you need to know, there's actually 3 different types of estrogen. So when we talk about estrogen, we're really talking about what we call E2 or estradiol. Notice the diol is the 2 part. We have estratriol, that's E3. And estrone is E1. So we're talking about estradiol. So here's the before and after, right? While they're fertile, they have a lot of estrogen, and afterwards they don't. And the average age of menopause is actually 49 and a half. Here it says 50. Who cares about the difference? And that's where the problems start. What does estrogen have to do with choline? Well, when estrogen, let's look at this here. Estrogen, estradiol, comes in and it hits this gene called PEMT, and a certain part of that gene it connects with, there's a receptor for it, it has a lock and key, and it goes, great! It turns in the lock and it starts generating some choline. Well, estrogen kind of disappears, so there's no key to go into the lock, so choline doesn't get produced. So all women end up being the same postmenopausally, but some women premenopausally who have this SNP, the key could never fit into the lock, so they could never produce their own choline. They were SOL, seriously SOL, and somebody needed to tell them, you need to eat choline because you're having babies, because you're fertile, and this is what you need to do, but they were not instructed on that clearly. So when estrogen just can't do its job, meaning you have this SNP, single nuclear polymorphism, and this is the name of this SNP, which is pretty famous at this point now, reduces the activity by 30 to 40%, and even far more than that. So the problem is, this doesn't work for many women who have this SNP. Estrogen doesn't help them make choline, so they will be choline deficient if they're not eating it. And here's what estrogen is supposed to do, right? Okay, so the key SNP is it limits the ability to create phosphatidylcholine. It's PEMT, phosphatidylcholine, methyltransferase. So this is the wrapping of the cell, right? So this is what happens in the methylation. This is the tail end of the methylation. There's SAMe. So remember I was telling you how back before anybody knew how all this works, they realized, well, SAMe helps some people. SAMe helps some women particularly. And it's like they didn't know why. Now you know why. It actually fills in that piece of the methylation system, but it also fills in the piece of the methylation system for people. 89.2% of the population of the United States are choline deficient. So it does fit. Summary of choline SNPs. This is a very short list, but two in particular. We're going to look at MTHFD1, and there we've just talked about PEMT, right? There's the SAMe. We just had this methylation reaction. So SAMe is called the universal methyl donor. But this over here, which I showed you about before, and I'll show you again, is that it's common enough when you start looking at it. It's not that esoteric. Is that what people have, if they're homozygous, they're locked up. They have a problem. So here you go. This takes the methyl group, right? Takes it down to MTHFR, which then methylates your folate, which brings it up to B12 and gets it so you can reduce homocysteine, which is a neurotoxin. This is how it works. Or if you want to go further, you can call it the glutathione factory, which we used to call it. A SNP that many people have is MTHFD1. And what this does, and there's the other name for it, by the way, that's how you Google it that's what you put in for Google, for Snipopedia. So now we have a problem. So it reduces the enzyme function. Preclinical data shows 38% reduction in transcriptional activity. So now they're really slowing down. This is just one SNP, by the way, critical SNP. Animal studies indicate 50% decrease in folate synthesis, disrupted folate metabolism, and purine biosynthesis, basically creating other DNA growth. So it's a big deal. So if you're thinking of a little baby who's growing or a fetus is growing into a child and it doesn't have these things and it's not getting the extra. So how you can overcome this, by the way, this isn't a mutation that, oh, this child will die like cancer. No, this can be overcome with making sure you have enough choline and enough folate and B12. Many studies on pregnancy outcomes. This enzyme is in the folate pathway, but it affects your needs for adequate choline in the diet. MTHFD will impact your body's ability to create phosphatidylcholine. So that wrapping of the cells isn't going to be wrapped too tightly. We're going to have some problems there. Is any of this really relevant to us personally? Have I been so esoteric that if I was to go, hey, let's go get a genome report on you and see what you got going, since I've shown you some of mine, let's see some of yours. It's not. It's common enough. And what I find from the lots that I've done, a lot, is that there's often people who do have a problem with folate and B12 will have a problem with choline. It's like all three are either a problem or they're not a problem. And I've met a lot of people who have no problem with any of this. So this is like, oh, that's neat. That's a nice story, but it doesn't apply to me. Is that what you're saying? Yeah, it doesn't apply to you. So again, this is what I found on me. Heterozygous for the MTHFD, homozygous for the MTHFR, which is the worst down here you can have, and you can look that up later if you want. And they're, again, just popping around, looked at somebody else. So here's the deal. Here's where MTHFD1 comes in, from folate to MTHFR. This is delivering the goods from you eating whatever source of folate you have. Egg yolks, it is in egg yolks, but it's more liver. Folate is higher in liver than egg yolks. So this is after my liver pate on an egg yolk waffle. And these are some of the SNPs that will make it a problem. So these colors are my colors. Purple means slow. Yellow color means intermediate, no problem. And then orange is fast. I don't have any orange, but I have a lot of slow ones right here. So I have a problem, and certainly we know that I'm MTHFR very slow there. And I'm not that unusual, by the way. Now here's the bigger picture. So now we're looking at the bigger picture. We were all looking at that, how we came down to MTHFR. And so MTHFR, what does that do? Helps us methylate folate and then to B12 and helps us reduce homocysteine. And hopefully even further, make glutathione. So anyone seeking support for cognitive, liver, or muscle function should be interested in this as well. When to suspect inadequate choline intake, poor concentration, disorientation. So you can either think of an older person, your partner, your parents, your grandparents, your great-grandparents. You go, oh, so that's why they're acting that way, more than likely. But unfortunately, it also happens in much younger people as well. Poor concentration, disorientation, many memory problems, confusion, hepatic lipid liver fat accumulation. Inadequate choline intake affects liver fat metabolism. So hepatic triglycerides, and that's how you're seeing fat both in your serum and in your liver. It's a triglyceride. hepatic triglycerides accumulate. The accumulation, fatty liver is what they're talking about, is the key. It's what they call the diagnostic criteria, fatty liver. So and fatty liver is actually a very general term. It's diagnosed by MRI. They go, you have a large liver. That's what a fatty liver would be. That's a large liver. So otherwise known as non-alcoholic fatty liver disease. And it also could be, if they're an alcoholic or if they're drinking a lot of alcohol, it could be alcohol-induced as well, as we saw. So here's a dose-response relationship between the average daily choline intake and verbal and visual memory performance. Pretty straightforward. You take choline, we see how smart you're going to be, right? So it's a very specific test. It's verbal memory and immediate recall. These are two different doses. This is a lower dose, that's the higher dose, and it basically showed, and these are the quartiles, highest quartiles, lower quartiles. So basically saying the higher the dose, the better they all did. The lower the dose, they did poorly. Higher the dose, so that was on delayed recall, and this is on immediate recall. So they did better in both. So you're comparing the top one to the bottom one, saying, and this is immediate. This is like, do it, let's go test you. Have some. And so I would assume that they probably gave it in a form of some sort of medication to be very specific about how much they got so they can measure it. So that came out in 2017. This is not old stuff. So this is in non-demented adults. This is normal people you can measure. Non-demented adults, red lines indicate 95% confidence. That's a big deal. The forgotten men, as I call them, the most vulnerable group. Men have the highest long-term risk of choline deficiency, right? Ever since the end of adolescence through the rest of their life, they were roughly, they were 150 milligrams below the AI. And we already said that AI is too low. It's not high enough. So they're probably pretty chronically deficient because they have the highest requirement need, the 550 milligrams, for the longest period of time. Choline requirement, again, 550. They have the highest choline requirement for the longest period of time for life, which makes them the most vulnerable group. That's why they're the forgotten men. It's not as exciting to talk about them as it is about the difference between premenopausal and postmenopausal women, etc., and lactating, and all those needs are very special. Men are just, oh, you need a lot, just keep on having a lot. Nobody told them that. Okay, here again is that image of what the standards are and how nobody's making it. So here it says 550, men are, that's even half. They're even more deficient. Can you imagine that? Here's young men versus older men. They're 150 difference there and 200. So up the eggs and liver. So choline deficiency, especially in men with specific SNPs, is associated with infertility. We'll get into this later in another video, I promise. Cognitive impairment, sarcopenia, dementia to Alzheimer's. Now back to the topic of brain shrinkage due to choline deficiency in those with specific SNPs. The brain volume is decreasing. As you saw, it's what it looks like. Healthy brain versus non-healthy brain. And you can see you can have a healthy brain. So now I'm asking you to come into this little choices of, do you want A, B, or C? Don't be an alcoholic, so you can immediately improve. If you're an alcoholic, we have other issues. B is, let's start thinking about, in the very least, addressing this choline through whole food sources of food. That's egg yolks and liver, preferably egg yolks mostly. That's a big deal. We're actually thinking of getting chickens, since I talked to one of our clients and they got chickens because they were watching my video. And so I thought we should get chickens. We live in a HOA. I'm not quite sure it's possible. Anyway, your brain doesn't have to shrink. So here from the VitaCog study is what the changes are that can be reversed. That's all what they were talking about. It can be reversed. Drop that homocysteine, get that lab covered. Go find where you can go take care of this yourself and find out where you stand and do it a couple times a year. It's not expensive. So how did this happen? You know how it happened. Till next time. So if this is something that you're interested in, that is a topic that I obviously go deeper in terms of labs, in terms of how to do it, in terms of why you would want to do it, various topics, as you've seen that I've done in the past, then please let me know below in a comment. Till then.